Jai Hind and a very good morning to respected principal sir, all the esteemed head of the departments, faculty members and dear students. Warm greetings from Swami Vivekanand, Subharti University. The university was established under the aegis of MTV Buddhist Religious and Charitable Trust Merit, guided by the vision of Siksha, Seva, Sanskar and Rashtriyata. Over the years, the university has created a remarkable legacy in the field of healthcare, education, and social welfare. We express our heartfelt gratitude to our visionary founders, Dr. Atul Krishna sir and late Dr. Mukti Bhatnagar ma'am, and our very young and dynamic CEO, Dr. Shalya Rajma, whose dedication continues to inspire us. Swami Vivekanand Subharti University houses 19 colleges under one roof, and amongst them, Subharti Dental College and Hospital stand as a pioneer and pride of the institution. As part of our ongoing commitment to the academic excellence, Subharti Dental College and Hospital is delighted to begin the Alumni E-Lecture Series 2025, celebrating the achievements of our distinguished graduates. I, Dr. Isha Maheshwari, Assistant Professor in the Department of Oral and Maxillofacial Surgery, feel privileged to welcome you all today. It's my honor to invite Professor Dr. Apurva sir from the Department of Oral and Maxillofacial Surgery to kindly extend his welcome and give a brief introduction for the speaker of today's session.
Jai Hind everyone. On behalf of the Department of Oral and Maxillofacial Surgery, Subharti Dental College and Hospital, I extend a warm welcome to all of you for the Subharti Alumni Lecture Series. This initiative is one of the best practices being initiated by our institution aimed at strengthening and fostering the academic culture and celebrating the achievements of our distinguished alumni. As already highlighted by Dr. Isha Maheshwari, Subharti Dental College and Hospital is one of the 19 colleges under the Swami Vivekananda Subharti University and proudly holds the distinction of being the first institution to be established in the year 1996. Today, it is my proud pleasure to host one of our alumni as a guest speaker, Dr. Richik Tripathi. Our esteemed speaker, Dr. Richik Tripathi, completed his M.D.S. in oral and maxillofacial surgery from Subharti Dental College and Hospital. He is of the batch 2008. Dr. Tripathi completed his B.D.S. from Magad University, Bodh Gaya, and since has built an illustrious career and academics. He is currently serving as a professor in the Division of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Institute of Medical Sciences, Banaras Hindu University. Dr. Tripathi has more than 35 publications to his credit in various national and international journals. He has also edited two academic books. His excellence is recognized globally. He has been awarded a prestigious scholarship to present his research at the ICMRI conference, Seoul, South Korea in 2019. Further, in 2022, he completed his Ph.D. in oral and maxillofacial surgery from Banaras Hindu University. In the same year, he was conferred the fellowship of the International Association of Oral and Maxillofacial Surgeons. In 2023, he received the highly esteemed fellowship of the Royal College of the Physicians and Surgeons of Glasgow, that is FICS Glasgow. Dr. Tripathi has vast experience in managing maxillofacial trauma, oral cancer, and head and neck pathologies. He is also a leading implantologist and is known for his extensive work on the management of bony lesions using artificial, natural bone substitutes. It's my privilege and pleasure to have him here with us today as a part of the SALS, which we commonly call it as, that is the Subharti Alumni Lecture Series. Now, without taking any more time, let us listen to talk to him on the management of cystic lesions of the jaws, recent trends, and update.
Morning, respected Nikhil Sharwartwa sir, respected N.K. Sahu sir, and all the delegates. This presentation is about the management of cystic lesion of the jaw and the recent updates. I am Dr. Richik Tripathi. I did post-graduation from Subharti University during the year 2008 to 2011. After that, I did Ph.D. from the Banaras Hindu University and appointed as assistant professor in the BHU. And right now, I am working as a professor in the same institute. Before I start the presentation, I would like to honor my teachers, Professor Sanjeev Kumar sir, who inspired me to achieve high qualification and to become an excellent clinician. Professor Vishal Bansal sir, he was a great teacher and he has outstanding teaching skills. Professor Arun Kumar sir, he guided me to keep the patient record and to keep good photographs of the patient. Without this, a good publication is not possible. Dr. Apur Mawal, Dr. Anurag Yadav, Dr. Gagan Khare were the pillars of my strength. I acquired most of my clinical skills from them. Dr. Dubeji is like my elder brother. He is very concerned about my progress and he accompanied me like a shadow from my first year to the final year of the post graduation. Now, definition of a cyst. A cyst is a fluid-filled cavity which is lined by epithelium. This epithelium may be derived from the inflammatory cells, from the odontogenic tissue or the non-odontogenic tissue. The first figure is of a typical periapical cyst which is formed due to the necrosis of the pulp and the lining is formed by the inflammatory cells. The second picture is of a dermoid cyst. We can clearly see the lining of the dermoid cyst and it is different from the oral mucosa. The pathophysiology of the cyst development. We can say that under the influence of inflammation, infection, hormonal imbalance, there may be random production of the cell. There may be excessive proliferations of the cells. However, the tumor suppressor gene which are present in the cellular environment immediately checks this excessive proliferation and the proliferation rate returns back to the normal. However, sometimes this tumor suppressor gene fails to check the excessive growth and there may be abnormal proliferation. So abnormal proliferating cells, if able to maintain the vascular supply and there is continuous amplification of the situation, they transform into the tumor mass and tumor mass grow by the further proliferation of the tumor cells. However, if there is irregular amplification of the situation and vascular supply is not maintained, the central part of the proliferated cell undergo necrosis and become a fluid-filled cavity, what we call a cyst. I have explained the pathophysiology of the cyst of the odontogenic origin. Now we can see clearly that how a duct blockage can lead to the retention type of the cyst. This mechanism is responsible for development of the cyst of the salivary gland and cyst of the maxillary sinus. Now look at the diagram. There is a periapical infection due to the carious tooth. Due to this infection, there is continuous inflammation at the periapical area and there is proliferation of the periapical cells. After inflammation subsided, there is central necrosis of the cells. This is because the vascular supply is not maintained. The necrotic cells has high osmotic gradient, high osmotic concentration. So it draws the fluid from the extracellular spaces, now become a typical cyst. The radicular cyst or the periapical cyst. Recent advancement in the cellular biology indicate that a single factor is not responsible for the cyst initiation. Rather than there are multiple factors which play in a complex fashion. Any imbalance in between these signaling pathway can lead to the initiation of the cyst formation. For example, WNT signaling pathway responsible for the growth and maturation of odontogenic epithelium. CAMP signaling pathway responsible for growth and maturation of mesenchymal cells. mTOR pathway, growth and maturation of the cells and maintenance of the protein metabolism. This mTOR pathway is greatly altered in the odontogenic keratocyst. So any imbalance in between these factors can lead to the initiation of the cyst formation. Now theories of cyst expansion. Osmotic pressure theory explains that the central necrotic mass has high osmotic concentration compared to the extracellular fluid. So there is movement of the fluid from the extracellular space to the inside of the cystic cavity. Epithelial cell proliferation explains that there is continuous proliferation of the epithelial lining of the cells, which increase the surface area and contribute to the expansion of the cyst. Bone resorption theory. It explains that there are a specific receptor on the wall of the cyst and they activate the cytokine and prostaglandins, leading to the activation of the osteoclast and bone resorption. The nutritional deficiency theory explains that the central mass has poor vascular supply and poor nutrition, so it undergoes the liquefactive necrosis. In the expansion of the cyst, a single mechanism is not responsible, but at least two or three mechanisms works collectively in the expansion of the cyst. Maxillofacial cyst can be simply classified into the two different types, developmental cyst and the inflammatory. The developmental cysts are further classified into the odontogenic cyst and the non-odontogenic cyst. Odontogenic cysts are those which are derived from the odontogenic epithelium, and non-odontogenic cysts are derived from the non-odontogenic cells. Developmental odontogenic cysts are the dentigerous, gingival cyst, keratocystic odontogenic tumor or the OKC, glandular odontogenic cyst, calcifying odontogenic cyst, and lateral periodontal cyst. Inflammatory types are the radicular cyst and the residual cyst. The non-odontogenic developmental cyst, nasopalatine duct cyst, narrolabial cyst, dermoid and epidermoid cyst, thyroglossal duct cyst. The pseudocysts, which don't have a true epithelial lining, the solitary bone cyst, aneurysmal bone cyst, the cyst associated with the maxillary sinus and the soft tissue, the cyst of the maxillary sinus and the retention cyst, mucocele, the soft tissue cyst, dermoid and lymphoepithelial cyst. Diagnosis of a cyst is a multi-step procedure. First of all, the palpation or the fluctuation test. It is indicated for cysts located peripherally or located in the skin. Suppose there is a swelling and we place two fingers over the swelling and push one. So there will be movement of the fluid felt on the another finger. This is the positive fluctuation test. Second test is the aspiration. It is indicated for those cysts or the tumor located deeply inside soft tissue or deeply inside bone. A positive aspiration confirms the presence of a cyst in a particular area. Radiograph. The cysts are represented as well circumscribed mass having the smooth borders and usually oval in shape. In the CT scan, depending upon the Hounsfield unit, one can accurately tell if there is a semi-solid mass, if there is a fluid, or if there is a solid mass. In the MRI, it is the electron and proton density which describe if there is a solid mass, if there is semi-solid or a fluid inside a particular cavity. The management options are marsupialization, enucleation, and resection. Marsupialization is the creation of a window in the cyst wall. So the contents of the cyst are drained and there is a positive pressure inside the cyst wall, which leads to the shrinkage of the cyst and gradual formation of the new bone around the cyst cavity. In this figure, we can see that there is a dentigerous cyst and it is in proximity to the inferior alveolar canal. So once there is opening of the window, the cyst content will be drained outward and there will be gradual shrinkage of the cyst lining and formation of the new bone. Marsupialization is indicated in the large cyst when there is a chance of injuring the vascular structure or the neural structures nearby. Sometimes marsupialization is performed to preserve the unerupted teeth. However, it depends upon the angulation of the tooth and the height of the available bone for the eruption. Otherwise, we cannot preserve the tooth. The children and young adults has high regenerative potential. So marsupialization is the procedure of the choice in the children and in the young adults. Enucleation is the complete removal of the contents of the cyst and the cyst lining. In the figure, there is a periapical cyst. So after the elevation of the flap and creation of the bony window, the cyst lining is completely removed and mucosa is sutured back. Enucleation is indicated in a small to moderate size of the cyst and whenever there is a recurrence. A histopathology report must confirm the benign nature of the cyst. Contraindications are very large cysts. In the large cysts, additional procedure may be required, such as the marsupialization or the resection of the bone. In the case of the suspected malignancy, we have to remove additional healthy bone with 1 centimeter margin. In the case of severe infection, there is likelihood of contamination of operative field and the spread of the infection from one side to the another. The recent evidence suggests that residual cysts and recurrences are more common in cysts larger than 1 centimeter. This is because as soon as we remove the lining from a bony cavity, this bony cavity is filled up with the blood. If the blood clot fails to organize, the residual cyst will develop. The recurrences are common because there is epithelial migration of the odontogenic cells or the non-odontogenic cells inside the bony cavity, so they can contribute to the recurrence. The artificial bone substitute are advocated for filling the defect. They act as a scaffold for the growth of the new bone, and they also prevent the epithelial migration of the odontogenic or the non-odontogenic cell. Furthermore, due to the bone graft placement, we can get better quality, better quantity of the bone for the placement of the implant. And also, the healing time is greatly reduced. This is the case of the recurrent odontogenic keratocyst. So after the elevation of the flap and creation of bony window, the entire cystic contents were removed and the iliac crest bone graft was used to fill the defect and stabilized with the help of the iliac plates. This is 1 month post-op OPG showing very good osteogenesis inside the cystic cavity, and within the 1 year there is a complete formation of the bone inside the cyst cavity, and we have successfully placed dental implant in that area. You may wonder why the plates were not removed before placement of the dental implant. This is because there is sufficient space of more than 5 mm exists between the screws of the plate to the dental implants. This 5 mm space is considered as a safe margin. This is the another case of the cyst enucleation. This is a periapical cyst in relation to the premolar and the canine. So after the enucleation, hydroxyapatite bone granules are used to fill the defect, and calcium phosphate bone cement are used to stabilize the bone graft inside the cystic cavity, bony cavity. So within the 3 months, there is complete healing of the bone and it is ready for the placement of the implants. Resection is indicated when there is extensive resection of the bony cortex due to the expansion of the cyst wall. Sometimes there is a through and through perforation of the bony cortex, creating a complex defect, which can only be managed by resection technique and bone grafting. So when a part of a segment is resected, it is called marginal resection, and when whole segment is resected, it is called segmental resection. In the last 20 years, there is a great development in the field of radiodiagnosis and the CAD/CAM technology. Before this, a surgeon has to work really very hard in deciding how to cut the bone graft, how to fit it accurately so that aesthetics and facial symmetry is maintained. But after this advantage and the advantage of the virtual surgical planning, a surgeon can predetermine. He can predetermine the size of the bone graft required, how to cut it, how to fix it. Moreover, he can check the symmetry of the face before the surgical procedure. The patient-specific implants are another breakthrough, which are made through the CAD/CAM technology. If the patient is not willing for the bone graft or not willing to donate the bone graft, the patient-specific implants are indicated. They are also indicated if the autologous bone graft has failed. The sliding osteotomy technique is the modification of the sagittal split osteotomy and has recently been highlighted for closure of the small segmental defects of the mandible. So after these technologies, the dissection osteogenesis is slowly losing its credibility due to because it is the lengthy procedure and the patient cooperation is very poor. Now this is the case of a large defect in the body of the mandible. So using the CAD/CAM technology, we have constructed a dummy fibula in which there is accurate reproduction of the cutting point. One point was straight, another point angled at the 45 degree. And this is not over. There is analysis of the facial symmetry. We can analyze the symmetry of the face after placement of the bone graft, all virtually before the surgical procedure. So it is the post-op OPG 1 month following the placement of the fibula, showing the very good integration in the bone and the mandible, the facial profile before the surgery and after the surgery. We can see the aesthetics and the facial symmetry is well maintained. This is the case of the patient-specific implant. The patient-specific implants are constructed using the CAD/CAM technology. In this patient, following resection, the patient-specific implant was placed because patient was not willing to donate the bone graft and she was not willing for the dissection osteogenesis. So this was the procedure of the choice to place the patient-specific implants. Sliding osteotomy is a modification of the old technique of the sagittal split osteotomy. We can see that there is a 1.5 centimeter defect, anterior segmental defect. So marking was done on the 3 centimeter from the edges of the defect on the buccal cortex and 3 centimeter on the lingual cortex. Following sagittal split osteotomy, the segments are moved forward to close the defect such that the 1.5 centimeter remains in contact with the body and 1.5 centimeter of the bone fills the defect. This is the post-op radiograph 6 months after the surgery showing very good bone formation and patient is ready for the placement of the implant. For the cyst located within the soft tissue, the enucleation is the procedure of the choice. This is because the cyst lining is there is adhesion of the cyst lining to the soft tissues, which cannot be removed through the marsupialization alone. The marsupialization is indicated to reduce the size. Following this, we have to enucleate to completely remove the lining of the cyst. If the salivary gland is involved, we have to remove the gland to prevent the recurrence. And there is lot of debate going on to preserve or not to preserve the gland if only ductal part is involved. Now the conclusion, in the last 20 years, there has been enormous development in understanding the cellular changes that lead to the initiation of the cyst formation. There are major advances in the radiodiagnosis which help us to diagnose and manage the treatment planning. Biomaterials can be a proven alternative to the natural bone. CAD/CAM integration with the radiodiagnosis is a significant breakthrough in surgical planning and recurrences morbidity is on decline due to these advancement. Thank you.
Thank you so much, sir, for enlightening us on such an important topic, the management of cystic lesion of the jaw, recent trends and updates. Now, few of our PGs have queries regarding this topic. I'll be presenting the query one by one. Please answer these queries. First is by Dr. Kamlesh. Question is, in your experience, how should the teeth associated with the cystic lesion be managed? What factors guide the decision between the extraction, preservation, or the endodontic intervention?
Okay, this question is very important, and I appreciate this question. Okay, so the tooth and the periodontium, you can divide it in the three parts. Number one is the apical third. Number two, the middle third, and number three is the coronal third. If only if only apical third is involved, we can proceed with the enucleation and root canal treatment. That depends upon the vitality of the tooth. Maybe vital, maybe non-vital. Okay. If the middle third is involved, this is the 50-50 condition. Maybe, may not be. So in that condition, there is always RCT followed by the enucleation and the placement of the bone graft, and the patient is kept on the wait and watch method. Third one is the involvement of periodontium or the tooth more than the middle third. So in this condition, irrespective of the size of the cyst, we have to extract it.
Thank you so much, sir. I hope Kamlesh, your query is answered. Next question is by Dr. Harshit. Can minimally invasive or endoscopic techniques play a role in the management of cystic lesion of the jaw?
Minimally invasive endoscopic surgery plays a role in the management of the cyst of the maxillary sinus, but it is not indicated if the cyst is located within the soft tissue or in the mandible. That is because there is adhesion of the cyst lining to the soft tissue, maybe to the bone. So we have to perform the peripheral osteotomy or additional excision of the surrounding soft tissue. So this is not possible with endoscopic surgery. However, at the maxillary sinus, this is open cavity, wide cavity, we can perform this surgery conveniently. So endoscopic surgery is mainly indicated for the cyst of the maxillary sinus.
All right. So next question is by Dr. Himani Sharma. What is the diagnostic reliability and clinical significance of aspiration fluid analysis in the preoperative evaluation for the jaw cyst?
The aspiration is very significant diagnostic test. It confirms the presence of a fluid inside a bony cavity or the soft tissue cavity, but it does not confirm the presence of the cyst. We have to move further. We have to do additional diagnostic tests, CT scan, MRI, to confirm the presence of an epithelium. If epithelium is present, it is a cyst. If epithelium is not present, it can be any other pathological entity.
So next question is by Dr. Taizi. What are the recommended management protocols for large mandibular cyst to reduce the risk of pathological fractures? Are the techniques like dredging effective for large lesions?
Okay. So there is no clear-cut consensus on when to reject, when to marsupialize, or when to enucleate a large cyst. There are three factors. Number one, how close they are to a vascular structure, and what is the condition of the surrounding bone. If there is more than 5 mm of the bone is present around the cyst walls. And number three, that some patients want to return to work as early as possible. And marsupialization is very, very lengthy procedure. So in this condition, we have to enucleate and place the bone graft. However, for early reduction for the good surgery, marsupialization is indicated to reduce the size, followed by the enucleation and the bone graft.
Okay, sir. Next question is by Dr. Nishant. What are the recommended management protocols for the large mandibular cyst to reduce the high risk of pathological fractures? In your opinion, are the techniques such as dredging effective for large lesions?
Effective large lesion. I don't understand what is the question.
So they
Please
want to
ask
know the
again.
management for large mandibular cyst to reduce the risk for pathological fractures. In your opinion, what is your take that are the techniques such as dredging effective for operating for the large lesions?
If more than 5 mm of the bone is present around the bony walls of the cavity around the cyst margins, we can perform marsupialization to reduce the size. If this condition is not achieved, we can go for the enucleation, resection, and placement of the bone graft.
All right, so last question. How would you manage the recurrent cystic lesion differently from the primary lesions?
Recurrence is always difficult to manage. When to a most trained professor, more trained surgeon, recurrence is always difficult to manage. Suppose there is a first time recurrence, we can go for the aggressive resection, peripheral osteotomy, use of the chemical cautery to reduce the recurrence. But if there is a second time recurrence, we have to perform either the resection or resection with placement of the bone graft to reduce epithelial migration and the recurrence.
Thank you so much, sir. I hope to all our students their queries have been clear. So at this moment, I would like to request our principal and dean, Dr. Nikhil Srivastav, sir, to kindly felicitate our esteemed guest speaker and address the gathering.
Hi, Richik. Good morning.
Good morning, sir.
Good morning, Eric. Thank you very much for joining us. I hope you know this thing that we had recently started some 3, 4 years back to engage our alumni, and we have this best practice with the name of SALS, which is Subharti Alumni Lecture Series. And uh, I couldn't listen or attend your lecture fully, but whatever I could understand, it was really informative and pertaining to the BDS students, right? Obviously, you as oral surgeon, for you maybe the management of cyst is a simpler thing, but for a general practitioner or graduates or postgraduates from other departments, it is a difficult and complicated things. But you have taken it very, very easily, and I hope that all the students must have understood this. And I was just hearing the conversation. They had raised a few queries also, and I think they were satisfied with your reply. And today, today we have our alumni meet today and tomorrow. And also we are celebrating the Silver Jubilee for 2000 batch. So
Okay.
yes, but I was just talking to my faculty members that from next year onward, I mean, do not confine to only the Silver Jubilee batches, but all the batches should be invited so that everyone can come. You can see the development of your own college, your own department, and how your faculty is working, your postgraduates are working, and you can contribute physically also, not only the online or digitally, right?
Okay. Thank you.
So thank you very much, Richik. And on behalf of Subharti Dental College, kindly accept this certificate of appreciation. And thank you again for your time and efforts.
Thank you. Thank you. Thank you.
Thank you very much. Thank you.
Thank you very much. लेक्चर हमेशा छोटा होना चाहिए। अगर आप ज़्यादा बढ़ा दोगे तो बोरिंग हो जाता है
Thank you
बहुत।
very much, sir, for your inspiring and thoughtful words. I extend my sincere appreciation to our esteemed guest speaker for sharing his invaluable knowledge and clinical insights with us today. I also express my deep respect to Dr. Atul Krishna sir and late Dr. Mukti Bhatnagar ma'am, the visionary founders of Subharti Group of Institution, for laying a strong foundation through the unwavering support and guidance. I would like to convey my heartfelt gratitude to our young and dynamic CEO, Dr. Shalya Raj ma'am, and our respected Vice Chancellor, Dr. Pramod Kumar Sharma sir, for their constant encouragement and leadership, which continue to inspire us to strive for the excellence. I am especially grateful to our principal and dean, Dr. Nikhil Srivastav sir, for his continued mentorship and motivation, always guiding us towards the academic and professional growth. A special word of thanks to our PPD and IT team with all the administrative team of Dental College and all the members of Dental College whose dedicated efforts made this lecture series seamless and successful. Thank you all for your gracious presence and participation. Have a pleasant and productive day ahead. Jai Hind.